Welcome once again to the class on endocrine system. In this third and last part of the endocrine system, we are going to look at the adrenal glands and the pancreatic islets of Langerhans primarily. But we'll also mention something about the gonadal hormones. Just to orient you on where we've been before, remember in the first part of the lecture on endocrine system, we looked at introductory concepts of the endocrine system. Then we also looked at the endocrine glands of the head region. So we focused on hypothalamus, pituitary, and pineal gland. Then on the second part of the lecture series, we looked at the endocrine glands in the neck region, where we focused on thyroid, parathyroid, but we also took time to look at the hormones that regulate calcium metabolism. So in this third and last part, we are going to look at the endocrine organs in the abdomen, primarily focusing on adrenal gland and the pancreatic islets of Langerhans. But we'll also look at the endocrine components of the testes and the ovary. So that's our agenda in this lecture. I'll remind you about the objectives that we had for each of the endocrine gland. Remember, for each endocrine gland, we expected to know the anatomical location where the gland is found. And then we are also going to describe the gross anatomical parts of that gland or organ, if that is applicable. After that, we'll mention the main parenchymal cell types, the cell types which are functional, the cell types that produce hormones. We'll mention them. And we'll also state the hormone that those cells produce. And for each of the hormones, then we will talk about the target organ or tissue. Where does that hormone act? And we'll also state the physiological effect that hormone has on its target organ. And lastly, if there's some clinical aspects to highlight, we will do so as well. So that's the objective for the lecture. Now let's start with the adrenal gland on that note. In terms of location, the adrenal glands are located on the upper poles of each kidney. And it is for that reason that they can also be called suprarenal gland. So supra means above, suprarenal means above the kidney. Adrenal means adjacent to the kidney. So yes, they are both adjacent to the kidney. And in particular, they're on top. And that's why we call them adrenal or suprarenal glands. In terms of the parts, each adrenal gland has two zones. The outer zone or the outer part of the gland is known as the adrenal cortex. The central part of the gland is known as the adrenal medulla. So that's the adrenal cortex. It looks more compact. It's all round than the adrenal medulla there. These two parts of the adrenal gland have different embryonic origins and different functions, as we are going to see. Adrenal cortex and adrenal medulla. So if we work with our template of the objectives, we've already indicated the location as the upper pole of the kidney. And in terms of the parts, we have adrenal medulla and adrenal cortex. Let me switch gear a bit and start talking about the hormones before I tell you about the cell types. The hormones produced by the adrenal medulla are the catecholamines. So this include adrenaline primarily, but we can also add noradrenaline and dopamine. But the main one is adrenaline, which is also called epinephrine. The cells that produce the catecholamines are known as the chromaffin cells. So those chromaffin cells are cells of neurocrest origin. They're the ones that secrete adrenaline. As opposed to the adrenal cortex, which produces steroid hormones. These steroid hormones are steroids from the adrenal cortex, and so we call them corticosteroids. The adrenal cortex produces corticosteroids. The cells that produce corticosteroids exist in some 3 not so well-defined zones. We give them names. We have what we call zona glomerulosa, zona fasciculata, and zona reticularis. Those zones of the adrenal cortex originate from the coelomic epithelium of the embryo. So they're not from neurocrest origin. That's what I mean. I want us to then discuss the 2 parts of the adrenal gland. Let's start with the adrenal cortex. Before that, maybe just a histology slide of the adrenal gland to orient yourself. So this is how it may look like sometime. Could be bean-shaped, or this is almost like a tongue, though. Depends on how stretched it is. So from this level, you can appreciate that the gland has 2 parts. The outer, more compact zone, and an inner zone there. The adrenal cortex and the adrenal medulla. Maybe a higher magnification of that captures that. That's the cortex and that's the medulla. But importantly, we also see in this slide that there's a connective tissue that covers the whole gland. So that connective tissue that covers the whole gland is the capsule. There's a connective tissue capsule that covers and therefore protects the whole gland. Then deep to the capsule, you have the adrenal cortex, which is more compact, and the adrenal medulla. At this magnification, you will note that the adrenal medulla contains some large spaces. These large spaces within the adrenal medulla are actually vascular channels. They are veins. We call them medullary veins. The adrenal medulla has several medullary veins, the veins that receive the catecholamines being produced by the chromaffin cells. A higher magnification of the medulla display to you that the cells of the adrenal medulla exist more in form of a cluster, just a cluster of cells, as opposed to the cortex. Look at that zone where the cells appear to exist in cords. So the cells of the medulla, the chromaffin cells, exist in clusters. And we have medullary veins interpassed between the clusters of cells. Remember, the cells of the medulla are called chromaffin cells. They produce catecholamines. The adrenal cortex, we can magnify this further so that we see something. Remember, that is the capsule, the connective tissue capsule, which is still down there. So from here all the way to there is the adrenal cortex. This is the capsule, the one down. So this zone of the adrenal cortex, where the cells, okay, first I want you to appreciate that the cells of the adrenal cortex seem to appear in cords. Look at that one. It's a cord-like arrangement. Now look at the cords near the capsule. They seem to appear like circular cords or arcing cords. So the region that contains the arcing cords is known as zona glomerulosa. Then from here, or around there, up to somewhere there, consists of cells arranged in columns. The cords are in columns, vertical columns or radial columns. That is what we call zona fasciculata. Zona fasciculata may have one cell thick cord or two cell thick cord. The gaps between the cords are vascular channels that allow passage of blood from the subcapsular zone all the way through the cortex to the medulla. Then this inner side of the adrenal cortex is what we call zona reticularis. This zone consists of cells which form a network. The cords form a network. Reticular means network or branching. Having said so, let's discuss the adrenal cortex further. I want us to start with the outermost zone of the adrenal cortex, that the zona glomerulosa. So in this image, let's take that thin one to be the capsule. This is zona glomerulosa. This is zona fasciculata. This is zona reticularis. And this is the adrenal medulla, if you extend it from there. Zona glomerulosa consists of cells arranged in arcing cords. The cords of the zona glomerulosa are arcing or circular. Remember, they're just beneath the capsule. This zone is stimulated by Angiotensin II hormone. So the cells of this zone are stimulated by Angiotensin II hormone. In response, the cells of this zone produce hormones which affect mineral levels. So we call them mineralocorticoids. Remember, we'd already said that the adrenal cortex produces corticosteroids, steroid hormones from the adrenal cortex, corticosteroids. But there are different types of corticosteroids according to the zones. The corticosteroids produced from the zona glomerulosa are corticosteroids which influence mineral levels, and so we call them mineralocorticoids. The main mineralocorticoid hormone is aldosterone. The aim of aldosterone is to promote the reabsorption or the retention of sodium and water in the kidney. That means that the target of aldosterone is actually the kidney. So it acts on the kidney, specifically in the distal convoluted tubule of the kidney, to promote the reabsorption of sodium, in which case even water will follow. Now, the reabsorption of sodium is usually in exchange with potassium, which means in the presence of aldosterone, an individual will lose potassium in urine. So it promotes potassium secretion as we reabsorb sodium and water follows. So if you reabsorb sodium and water follows, it means we are increasing blood volume. And if you increase blood volume, you are having an influence on blood pressure. Therefore, we can say that mineralocorticoids are hormones that regulate electrolytes, which means the concentration of solutes like sodium, potassium, and even just water itself. And also they regulate blood pressure. That's the role of zona glomerulosa, which means the role of the mineralocorticoids. Maybe while we are there, let's discuss what we call the Renin Angiotensin-aldosterone system. This is in light of the understanding that the zona glomerulosa is stimulated by angiotensin II hormone. This is a long chain of function of various chemical messengers. Let's look at them. So we have what we call angiotensinogen. It's a protein produced by the liver. This protein produced by the liver is released into the circulation. So it's just circulating within the vascular system. Angiotensinogen become converted to what we call angiotensin I, which is kind of an intermediate hormone. The conversion of angiotensinogen to angiotensin I occurs primarily within the circulation. Angiotensinogen is circulating in the peripheral blood, and so that conversion occurs within the circulation. However, it requires a particular enzyme, and the enzyme it requires is the one we call renin enzyme. And that is why renin is in this particular title. So renin enzyme converts angiotensinogen to angiotensin I. But where does renin come from? Renin comes from the juxtaglomerular cells of the kidney. The kidney has some cells within it that are called juxtaglomerular cells. Those juxtaglomerular cells are the ones that produce renin enzyme. The trigger for production of renin enzyme seems to be either a fall in the blood pressure, or if there is low level of sodium being delivered in the distal convoluted tubule, or if there is increased sympathetic activity. So increased sympathetic activity, low levels of sodium in the renal tubules, and a fall in blood pressure will all stimulate the juxtaglomerular cells, well, maybe indirectly, but will cause the juxtaglomerular cells eventually to produce renin enzyme. Now we have angiotensin I, which has been converted from angiotensinogen in the presence of renin enzyme. Angiotensin I become converted to angiotensin II. The conversion of angiotensin I to angiotensin II is done by an enzyme called angiotensin converting enzyme ACE. This enzyme is produced by the endothelial cells of the lung capillaries. Remember, endothelium referred to the inner lining of blood vessels. So the capillaries within the lung, capillaries around the alveoli, have endothelial cells. Those endothelial cells are the ones that produce this enzyme. You can call it ACE. ACE converts angiotensin I to angiotensin II, and so angiotensin II is the active hormone that we're talking about in this particular context. What are the effects of angiotensin II? Angiotensin II acts on several target organs. It acts on blood vessels. And its primary effect on blood vessels is to cause narrowing of the lumen of blood vessels. This is because it causes the smooth muscle of the wall of blood vessels to contract. And so that causes narrowing. That is what we call vasoconstriction. Angiotensin causes vasoconstriction. And it is for that reason that perhaps it's actually called angiotensin. It is known that angiotensin II is perhaps the most potent vasoconstrictor in the body. Apart from blood vessels, angiotensin II also acts on the pituitary gland. In particular, it acts on the posterior pituitary gland, or what we call the neurohypophysis. The effect on the pituitary gland is to cause production of vasopressin hormone. Remember, vasopressin is also called antidiuretic hormone. So angiotensin II promotes the release of antidiuretic hormone. The other target organ is the adrenal cortex, the reason why we're discussing this. On the adrenal cortex, angiotensin II acts on the zona glomerulosa. And the effect on the zona glomerulosa is to promote the secretion of aldosterone. It is for that reason that therefore aldosterone is also under this particular title. And so the whole system is called Renin Utensinaldosterone system. There are two more target organs I want to talk about. Angiotensin II acts on the proximal convoluted tubule of the kidney. Don't confuse that with the DCT. Remember, DCT is where aldosterone acts. But here, angiotensin II acts on the PCT, proximal convoluted tubule of the kidney. The effect on the kidney, PCT, is to promote the reabsorption of sodium and water. Now, this is not in exchange with potassium. So it's just reabsorption of water and sodium from the proximal convoluted tubule. Lastly, angiotensin II also acts on the hypothalamus. The effect of angiotensin II on the hypothalamus seems to be related to increasing that desire for water. It increases your sensation of thirst. And so what do you do if you have that sensation of thirst? You take water, which means that it will give you that desire to take water. And indeed, you can give into that and actually take water. These are the effects of angiotensin II. Let's narrow down this effect this way. If you look at the first two, the narrowing of lumen, we've called that vasoconstriction. So angiotensin II acts on blood vessels to cause vasoconstriction. It also helps in promoting the secretion of vasopressin, which also causes vasoconstriction. So these two mechanisms lead to vasoconstriction. Because of vasoconstriction, it means that the blood vessels there are going to increase their peripheral resistance. It causes an increase in vascular peripheral resistance. And remember, that is one of the key parameters in the determinants of blood pressure, vascular resistance. So vasoconstriction leads to increased peripheral resistance or increased total peripheral resistance. Now, again, let's look at the last four, which means vasopressin also included. Those last four, what do they really do? The main aim of them is to expand the blood volume because it means that we're increasing fluid. It increases fluid within the blood volume. So if we increase the amount of water within the blood volume, it means that we're expanding the blood volume. Now, the mechanisms of increase is because they increase the renal fluid retention. That means that kidney take more water back to the bloodstream. That means you produce less urine. And then, of course, based on the role in the hypothalamus, an individual is likely to take water. Again, that will be absorbed, and so it will still increase blood volume. Increase in blood volume increases preload. Preload is the volume of blood that goes to the heart. Now, if you remember from your vascular physiology or physiology of blood pressure, if you cause vasoconstriction and you also expand blood volume, basically that will raise the mean arterial pressure. And so the renin angiotensin aldosterone system is a system that helps to raise the mean arterial pressure. And that is why, therefore, in the management of hypertension, in the management of high blood pressure, some of the drugs which are used in that management are actually drugs which inhibit the renin angiotensin aldosterone system. They could be drugs that prevent, that block the enzyme ACE. So we call them ACE inhibitors, the one that block the conversion of angiotensin I to angiotensin II. There could also be drugs which act on the receptors of angiotensin II, somewhere there or there or there. That means that inhibiting the physiological effects of angiotensin II on its target organs. So anyway, that is renin angiotensin aldosterone system. We had to talk about that one because we discussed zona glomerulosa. This image captures for you in summary what you said about the renin angiotensin aldosterone system. The liver produces angiotensinogen, which become converted to angiotensin I in the presence of renin enzyme. Angiotensin I become converted to angiotensin II in the presence of the ACE, angiotensin converting enzyme. Angiotensin II acts on several things. So for example, on the pituitary gland, on the blood vessels, on the adrenal cortex, on the proximal convoluted tubule itself. The effect on the hypothalamus, not indicated here, but I've already told you, and there's another one that has been indicated here that I didn't tell you, you can capture it as well. It increases the sympathetic activity. Okay, now we can talk about the second zone. The second zone of the adrenal cortex is called zona fasciculata. This is the zona fasciculata. Zona fasciculata consists of cells which are arranged in columns. The cords of cells are arranged in columns. These columns could be 1 cell thick or 2 cell thick. Maybe the one being shown there is 2 cell thick. I'm trying to look at ones which are 1 cell thick. Perhaps that one is 1 cell thick. The gaps between the columns are actually vascular channels, arterioles and capillaries that allow blood flow from the periphery towards the center. Zona fasciculata look like that as well. Look at that region there. The cells are in columns. And that is why it's called fasciculata. Fascicle means column. The cells of this zone become stimulated by the adrenocorticotropic hormone. Adrenocorticotropic hormone is also known as corticotropin. Remember, this hormone comes from the corticotrophs of the anterior pituitary. So it's an anterior pituitary hormone. The effect of the ACTH on zona fasciculata is to stimulate the production of glucocorticoids. Glucocorticoids are corticosteroids which affect glucose metabolism. So we call them glucocorticoids. The main example of glucocorticoid is cortisol hormone. So zona fasciculata produce cortisol. That's the message. What's the effect of cortisol? Glucocorticoids in general modify metabolism. They affect metabolism of carbohydrate. They also affect metabolism of fat, metabolism of proteins as well. They affect metabolism. They also have anti-inflammatory effects, and that's why the synthetic forms of glucocorticoids like hydrocortisol and prednisolone, dexamethasone are used as anti-inflammatory drugs. Last but not least, glucocorticoids also suppress the immune system. They're immunosuppressants, and that's why, again, they can be used as immunosuppressants in some conditions where you need immunosuppressive therapy. That is zona fasciculata. While we are there, let's talk about hypothalamo-hypophyseal adrenal axis. So we have hypothalamus, which produces corticotropin releasing hormone. Corticotropin releasing hormone acts on the anterior pituitary gland, which we call adenohypophysis. The effect of corticotropin on adenohypophysis is to promote secretion of corticotropin. See, this is corticotropin releasing hormone. Now this is corticotropin. The other name of corticotropin is adrenocorticotropic hormone, and that's why it's called so, adrenocorticotropic hormone. It is tropic to the adrenal cortex. In particular, it acts on the zona fasciculata of the adrenal cortex, and the effect is to promote production or secretion of glucocorticoids, cortisol being the principal hormone here. Right, that is zona fasciculata. Now we can talk about zona reticularis, the third zone of the adrenal cortex. Zona reticularis consists of cells which are arranged in branching pattern, branching cords. That's why it's called reticularis. Reticular means branching. The cells of this zone secrete the male sex hormones, and this is okay whether you are male or female. The zona reticularis produces androgens, male sex hormones. The name of these androgens may be a bit different from the testicular androgens. The androgens that come from the adrenal cortex are androstenedione, epiandrostenedione, and dihydroepiandrostenedione. Those are the androgens which come from the adrenal cortex. Well, they have almost similar functions as androgens which come from the testes. I prefer discussing androgen biology when you talk about the reproductive systems. And so we can just leave it there for now. Now let's talk about the inner zone of the adrenal gland, which we call the adrenal medulla. We've already talked about the adrenal cortex, which is that one with its three zones. Now let's look at the adrenal medulla, that one. The adrenal medulla consists of cells arranged in cluster, and we have vascular channels, several of them interpassed within the adrenal medulla. The cell types of the adrenal medulla are the ones we called the chromaffin cells. The chromaffin cells secrete catecholamines, adrenaline being the major catecholamine we're talking about. The secretions of the adrenal medulla is regulated primarily by the sympathetic division of the autonomic nervous system. So the sympathetic nerves are the ones that stimulate the chromaffin cells to produce the catecholamines. The effect of these catecholamines is simply, again, to mimic the effects of the sympathetic division of the autonomic nervous system. So it is stimulated by the sympathetic nervous system to augment the functions of the sympathetic nervous system. We can therefore say that adrenaline or catecholamine has sympathomimetic effects, biological effects that mimic the sympathetic stimulation. You can think about those ones. What are these sympathetic effects? And to help you understand that, I've picked for you some selected organs. I believe you've done autonomic physiology. And so you know the effect of the sympathetic nervous system on the eye, on the heart, on blood vessels, on respiratory system, and on the digestive system. So maybe I give you some 1 minute or two to just review the effects of sympathetic nervous stimulation on those organs, which means the effect of adrenaline on those organs. You have a minute. Right, you should be ready with that now. So now we can proceed. Let's talk about some endocrine disorders that affect the adrenal gland. There's one that you will come across in your clinical practice called pheochromocytoma. Pheochromocytoma refer to tumors of the chromaffin cells. These tumors are tumors that produce adrenaline. Basically, pheochromocytomas are catecholamine producing tumors. So majority will be within the adrenal gland, but a few are extra-adrenal. How do you know, or what to make you suspect that someone has pheochromocytoma? It will be more of the exaggerated physiological effects of the catecholamines. So features of excess catecholamine within the circulation. Largely will be seen in the heart, perhaps, and the blood vessels. Addison's disease is adrenocortical deficiency. It's a deficiency of the zona fasciculata as well as zona glomerulosa, so that there is a reduction in hormonal production, both glucocorticoids as well as mineralocorticoids. Conn's disease is a condition of hyperaldosteronism, excess levels of aldosterone. And Cushing syndrome is a metabolic disorder due to excess cortisol following excess ACTH. So if someone has excess ACTH, they'll have hypercortisolemia, and that will give them Cushing syndrome. The image you're seeing here is an image of a patient with Cushing syndrome. The hallmark is that they have abnormal fat deposition. As you can see, fat is deposited there and perhaps there and not there where you may want it to be. Right, that is adrenal gland. Now we can talk about the pancreas. In terms of location, the pancreas is located behind the stomach. We call that the stomach bed. Usually, it's around the curvature of the duodenum. If this is the duodenum curves around the pancreas. In terms of gross anatomical parts, the pancreas has a tail, which is that one extending to the left. It has a body, which is the major part. It has a neck, which is this region, or that region there, the neck. It has a head, which is this big part. or that one. The lower part of the head has a small extension, which we call the uncinate process. So that's the uncinate process. It's basically the lower part of the head. So those are gross anatomical parts. In terms of histological parts, which can double as functional parts, the pancreas is described to have two histological, which double as functional parts. We have the exocrine pancreas and the endocrine pancreas from a functional perspective. Exocrine means that they release secretions into a ductal system. Endocrine means that they release their secretions into the bloodstream. Maybe let's say something about the overall histology of the pancreas, then you understand what you mean by exocrine and endocrine. So the slide shown here is the slide of the pancreas. At this magnification, it's a lower magnification, we see a gland or an organ that is lobulated. So the lobules are of different sizes, some big, some small, they are lobulated. The gland is lobulated. We also note that the gland is covered by a thin capsule around, and maybe that capsule may also be having some fatty tissue, but that the capsule still sending trabecula, which is the one dividing the organ into smaller lobules. Let's magnify one of the lobules and see. So a magnification of the lobule shows something like this. Yes, we still have the trabeculae. We have several blood vessels, as we can see there. So it's highly vascularized. But then within each lobule, we appreciate that we have some cells arranged in acini form. We call those on the pancreatic acini. Then we also have these ones which appear as clusters. In this image, they are light staining. So these ones which appear as clusters, the light staining ones, are the ones which we call pancreatic islets of Langerhans. So these are pancreatic islets of Langerhans, those cellular clusters, and these are the ones at the pancreatic acini. A high magnification shows you a single islet there. It's a cluster of cells, and the rest will be the acini. Look at how the acini are arranged. We have some peripheral cells and a center. These are the acini, and these acini are serous acini because we can see they're taking up stains. Let's say something about the pancreatic acini, the exocrine pancreas, before we talk about the subject matter. So the exocrine pancreas consists of serous acini. This is how an acinus would look like. So we call them pancreatic acini. They're found all over the pancreas. These acini produce the secretions into a ductal system. As you can see, the acini are connected through the ductal system. And that is why this part of the pancreas constitutes the exocrine pancreas. Because the secretions are being released into ducts. The types of cells which are within the acini are the acinous cells, which produce the secretions, and centroacinous cells. Centroacinous cells represent the initial portion of the pancreatic ductal system found within the acinus. For example, here, this ductal system usually extend into the center of the acinus. And so the cells of the ductal system at the center of the acinus constitute the centroacinous cells. So that if you are to look at that in a microscope, perhaps this is what you see. Maybe not all of them will capture it, but let's look at that one. So these are acinar cells in the periphery, and at the center, you have the central acinar cell. These are a good example of central acinar cell. You have the acinar cells in the periphery, and you have the central acinar cell. So these are all acini. The pancreatic acini constitute about 70% of the total pancreatic mass. Big part. These acini produce pancreatic juice. The pancreatic juice is released into the pancreatic ducts and therefore taken all the way to the duodenum. You look at that one. So the ducts join eventually to the main pancreatic duct or an accessory duct, which drain to the duodenum. Pancreatic juice contain many elements. Of course, water would be part of it. But importantly, the pancreatic juice contain digestive enzymes, which help in the digestion of food. It also contain bicarbonate, which help to neutralize gastric acid. Now, that was exocrine pancreas, not our subject matter. Our subject matter is endocrine pancreas. Endocrine pancreas consists of clusters. They're scattered all over the pancreas, but they're clusters. We have cell clusters which are scattered all over the pancreas. These clusters of cells produce hormones. We call them the pancreatic islets of Langerhans because they exist as islets. So those are islets. They're scattered all over the pancreas and they produce hormones. These islets are heavily vascularized. And it's for that reason that they're able to actually produce their hormones into the bloodstream. Even though they are found all over the pancreas, the islets are all over the pancreas, the highest concentration of the pancreatic islets are in the pancreatic tail. So the pancreatic tail has a lot of them. It is estimated that there could be as many as even millions, like 2 million, over 1 million, let's say so. Even though there are that many, either way, if you have to look at their volume, the volume they occupy, remember the pancreatic acini occupy about 70% of total pancreatic mass. The islets of Langerhans occupy just 2% of the total pancreatic mass. So they're just clusters. There are really many, tiny, but in terms of volume, not so much. And I know you might be wondering, so where is the 28%? Now that will be accounted by the connective tissue elements of the pancreas. So that's an islet. That's another islet. We can see how vascularized they could be. You can see blood vessels there. But then these are the pancreatic acini, the one that produce pancreatic juice. There are several cell types within the pancreatic islets of Langerhans, but I'll only discuss 4 of them, which are the main ones: the alpha cells, beta cells, delta cells, and the PP cells. These are the cells which produce the major hormones of the pancreatic islets of Langerhans. So I'll approach this in a different way. I'll be mentioning the hormones first, then indicate the cell type that produce them, then the effect of the hormones. Let's start with the hormone glucagon. Glucagon is the one produced by the alpha cells of the islets. The alpha cells can also be called the A cells. The major physiological effect of glucagon is to elevate the blood sugar levels. So it raises the blood sugar levels. Think about the mechanisms that it will use to do that. Second hormone, insulin. Insulin comes from the beta cells of the islets of Langerhans. We can call them the B cells. Insulin has the opposite effect to glucagon. So it will lower the blood sugar levels. Again, think about the mechanisms that insulin would use to lower the blood sugar levels. Importantly, there's some things that need to come to mind. One of the key mechanisms that insulin uses to lower blood sugar level is to promote the entry of glucose into the cells. It promotes glucose uptake by the cells. So that means that glucose is redistributed from the plasma into the intracellular fluid. That will lower blood sugar level big time. But it also has other effects as well. For example, it also promotes the utility of glucose by the cells. So the cells utilize the glucose either by breaking it down, that's what we call glycolysis. It also promotes the conversion of glucose to glycogen for storage. So the aim is to just lower it. So it will promote the conversion of glucose to glycogen in the liver for storage. So it promotes glycogenesis, formation of glycogen. As you think about the mechanisms, also think about the mechanism that it's able to inhibit so that the sugar levels are not elevated. For example, it will inhibit breakdown of glycogen, glycogenolysis. It inhibits it. It will also inhibit the breakdown of fat, because if you break down fat, that fat can be used to form glucose. It inhibits lipolysis, breakdown of fat. It also inhibits the conversion of fatty acids to carbohydrates. That is what we call gluconeogenesis. It inhibits gluconeogenesis. So multiple mechanisms that insulin will work with. The overall aim is to lower the blood sugar levels. Somatostatin is the third hormone. It comes from the delta cells, which we call the D cells. I hope you've noted that we don't have C. We came from A, B, then now D. Somatostatin inhibit pancreatic secretions. Now, these secretions are both endocrine as well as exocrine. Somatostatin inhibits both the pancreatic acini and the islets of Langerhans, and more of the pancreatic acini actually. It inhibits more of the secretions of the pancreatic juice, but it also has influence on the islets. Last but not least, we have pancreatic polypeptide, which comes from the PP cells, and perhaps that's where the name comes from, PP for pancreatic polypeptide. We call them F cells. Again, you note that we don't have E cells. After D, we go to F. The main function of pancreatic polypeptide is not very clear, but we know that in the presence of pancreatic polypeptide, the absorption of food is slowed down. Maybe the mechanisms are not very clear. Right, so while we are there, I want you to attempt another exercise. This time round, we are going to attempt to explain the homeostasis of blood sugar level. What happens when the sugar levels are up? How about when the sugar levels are down? So now you have another 2 minutes to attempt that one. Homeostasis of blood sugar level. Great, you should be ready with that now. That one I would want us to review. So perhaps this is where you should get it. Let's assume that this is the normal sugar level. So that is the range. And you eat some meal, maybe heavy carbohydrate diet. So if you take a heavy carbohydrate meal, it will definitely raise the sugar levels. So the sugar levels go higher than normal. An increase in the sugar levels trigger your pancreas to produce insulin hormone. So you have insulin being produced into the circulation. Insulin works through many mechanisms, we said, one of them being just promoting the uptake of glucose by cells. The other one just being converted to glycogen from glucose. If you look at those mechanisms that insulin uses, it will aim at actually lowering the sugar level. So the sugar levels decline and perhaps decline to the normal that you want. How about if you've not eaten for long? You're fasting for hours. So if you fast, the sugar levels go down. And a decrease in the sugar levels trigger the production of glucagon hormone again from the pancreas. Glucagon now elevates sugar levels, again through multiple mechanisms, largely maybe promoting breakdown of glycogen to glucose, but it may also be promoting gluconeogenesis. So with those mechanisms, the sugar levels will be restored to a normal level. That is how blood sugar is controlled. As we talk about that, let's talk about some disorders of the pancreatic islet, the commonest one being diabetes mellitus. So diabetes mellitus is a condition where we have excess glucose. It's an endocrine disorder. It's a metabolic disorder characterized by high glucose levels. There are different types of DM. Type 1, diabetes mellitus, occur as a result of deficiency of insulin deficiency. But why is there insulin deficiency? Because something has destroyed the beta cells. So type 1 is insulin deficiency secondary to beta cell destruction. You may have type 1A, where the beta cell destruction is autoimmune destruction, and type 1B, where the beta cell destruction is idiopathic. The cause of the destruction is not known. Previously, this type of diabetes mellitus used to be called insulin-dependent diabetes mellitus because these patients rely on administration of insulin throughout life. Type 2 DM is due to insulin resistance. And there are different variants of type 2 DM, but overall thing is insulin resistance. The insulin is there, except that the signaling of insulin is the problem. So these ones were previously called non-insulin dependent diabetes mellitus. We no longer use those terminologies, largely because we know that all diabetics at some point may actually require insulin. But in the management of type 2 DM, which largely occur in adults, as opposed to type 1, which largely occur in younger people, in the management of type 2 DM, perhaps more of dietary management, and the drugs which are given are drugs which are not necessarily insulin-based, They use other mechanisms to lower the sugar level. Then we have type 3 DM. Type 3 DM is also called secondary diabetes mellitus. This is diabetes due to excess of counterregulatory hormones. A counterregulatory hormone is a hormone that raises sugar level. It can be growth hormone, like people with acromegaly or gigantism may be having diabetes. It could be cortisol, like people with hypercortisolemia may be having diabetic mellitus. Or it could be glucagon. For example, if a patient has a tumor that produces glucagon, you can call that glucagonomas. Those ones will also be diabetic. But diabetism due to excess of hormones which elevate sugar level, we call that secondary diabetes or type 3 DM. And type 4 DM is the diabetes we see during pregnancy. We call it gestational diabetes. You can check on the mechanisms. Right, so that is the pancreas. Now let's look at the two gonads briefly. We'll be focusing on the endocrine testis and the endocrine ovary. Let's begin with the endocrine testis. Now, in the structure of the testis, we have what you call the stroma and the parenchyma. Now, that's not unique to testes. Almost all organs will have a stroma, connective tissue component, and parenchyma, the functional component. The functional components of the testes are called the testicular lobules. These are the lobules. Testicular lobules contain seminiferous tubules, which you see here, highly convoluted tubule. These are the sites of spermatogenesis. If you take a cross-section through there, we see these are the seminiferous tubules, which are the site of spermatogenesis, being made up of complex stratified epithelium. However, between the seminiferous tubules, we have some loose connective tissue, which we call the interstitial tissue. This interstitial tissue is heavily vascularized. There are several blood vessels within this interstitial tissue. But in addition to the blood vessels, the interstitial tissue also contains some steroid hormone secreting cells, which we call the interstitial cells of Leydig. So the cells within this loose tissue, like those ones, interstitial cells of Leydig. These interstitial cells of Leydig are the ones that produce the testicular androgens. The key testicular androgens are testosterone and dihydrotestosterone. You can call it DHT, the last one. So based on that, let's revisit the hypothalamo-hypophyseal testicular hormonal axis. Hypothalamus produces GnRH, gonadotropin releasing hormone, that acts on the anterior pituitary adenohypophysis. The physiological effect of GnRH on the adenohypophysis is to promote the secretion of gonadotropic hormones, FSH and LH. Those two hormones act on the testis. The effect on the testis, FSH act on the seminiferous tubules of the testis, and they are primarily targeting the Sertoli cells. The physiological effect is to promote the process of formation of spermatogenesis. Luteinizing hormone, on the other hand, act on the interstitial cells of Leydig, and it promotes the secretion of testicular androgens, testosterone and dihydrotestosterone. So that is the hormonal axis that controls the secretion of androgens. Remember, the secretion of GnRH begins at around the time of puberty, marking the onset of puberty. Something about the androgens. Androgens are male sex hormones. and they are steroidal. They are steroid hormones, which means they'll be expecting to have their receptors inside the cell as opposed to on the cell membrane, although newer information tell us that you may also have some cell membrane receptors. But largely, the receptors are intracellular. Androgens are produced both by the interstitial cells of Leydig, which are from the testis, and the zona reticularis from the adrenal cortex. So the testicular androgens are those two, testosterone and dihydrotestosterone, while the adrenal androgens are these three, androstenedione, epiandrostenedione, and dihydroepiandrostenedione. Those are the androgens. What are the physiological effects of androgens? Androgens help in embryonic development of the male genital organs. So this is important before birth of a boy child. The androgens help in virilization. This is patterning towards the male system as opposed to female system, virilization. Androgens also promote spermatogenesis, formation of sperms. They're responsible for male libido. They promote bone and muscle mass, and importantly also, they promote development of the male secondary sexual characteristics like the breaking of voice, broadening of the chest, formation of beard and the like, pubic hair. Those are androgens. Now let's finish with the ovary. The slide I'm showing you is a slide of an ovary. I want us to first describe the histological structure of the ovary. So the ovary has a central zone, which we call ovarian medulla. The ovarian medulla basically contain connective tissue elements and blood vessels. Then we have the outer zone of the ovary, which we call the ovarian cortex. The ovarian cortex contain ovarian follicles at different stages of maturation. So you see some are large, some are tiny. Ovarian follicles at different stages of maturation. Those two components of the ovary are still being shown here. So this is the ovarian medulla with blood vessels and connective tissue, and this is the ovarian cortex. External to the ovarian cortex is a capsule that protects the ovary. The ovarian capsule is termed tunica albuginea. However, there's something external to the tunica albuginea. Usually, we have a layer of epithelial cells not shown here, which we call germinal epithelium. So, ovarian capsule consists of germinal epithelium, a simple cuboidal epithelium external, and the tunica albuginea. Maybe the previous slide has a better one. So this is the tunica albuginea, and if you look carefully, there's some thin cells on that other end, which we call the germinal epithelium of the ovary. Right, so that's the capsule. Now let's go deep. Deep to the capsule, we see some ovarian follicles. There are different types of ovarian follicles. The first one that I want to talk about are these ones, which we call primordial follicles. Primordial follicles exist in groups like this, and they're subcapsular. These follicles are largely made up of the oocyte surrounded by simple squamous epithelium. So we call them primordial follicles. When primordial follicles advance, they become primary follicles. What's the difference between primordial follicles and primary follicles? Primary follicles are slightly deeper. They also don't exist in groups. But importantly, the primary follicles are surrounded by cuboidal cells as opposed to the squamous cells. So these primary follicles are advanced from this level. They are the ones that are maturing. The primordial follicles are basically the functional reserve. Primary follicles have now been stimulated. They're now growing. The cells that surround the primary follicles, we want to call them the granulosa cells, as opposed to the ones that surround the primordial follicles that we call the follicular cells, although some people use them interchangeably. So we have the cuboidal cells and the squamous cells. Now, the primary follicles can also vary depending on how advanced it is. You may have a unilaminar primary follicle like that one layer of granulosa cells, unilaminar primary follicle. But you may also have a multilaminar primary follicle like this one, where the granulosa cells are of multiple layers. So just an advanced level. When this one matures up, it becomes what we call the secondary follicle or antral follicle. Importantly, the antral follicle has a cavity, which we call follicular antrum. So because of the presence of that cavity, we call it antral follicle. This cavity contains some fluid. But importantly, you also note that now the follicle has become big. And I want you to check just external to the follicle. You see the cells of the ovary are thinning out around the follicle. We call these on the stromal cells. So the stromal cells are thinning out. The name given to those stromal cells that are thinning out around the follicle is the theca folliculi, theca folliculi. So we can see theca folliculi forming already around the antral follicle. This follicle can be big, and I'll show you a slide where it's bigger than this one, but I want us to orient ourselves on the name of this structure. So this is the oocyte. These granulosa cells external to the oocyte are called the corona radiata. And this granulosa cell that suspend the oocyte are known as cumulus euphorus. And these granulosa cells external to the antrum constitute the stratum granulosum. Then external to that, we have the theca folliculi. Theca folliculi may also have two layers. We have theca interna very close to the follicle and theca externa away from the follicle. When follicles mature, they become even more and they increase in size. You can look at that one is larger than maybe that one. All those are follicles. Remember, as they mature, they now move closer to the surface, and the one that's most mature will actually be next to the surface, ready for ovulation. These ones have become big, and so these are follicles. Now, when ovulation takes place, this is the part that is ovulated. Only the oocyte and the zona pellucida that covers it and the corona radiata, that is what is ovulated. Then the remnants is what constitute the corpus luteum. So I want you to know that the cells that remain as corpus luteum are these one, the granulosa, the stratum granulosum, and the theca folliculi. Those ones will form the corpus luteum. So that's the histological structure of the ovary. Now let's talk about the endocrine ovary itself. I've told you that ovarian cortex contain ovarian follicles at different stages of maturation, and that a mature follicle has several cells. There are those cells which go after ovulation, and there are those cells which remain after ovulation. In this image, these are the corona radiata, this is the zona pellucida, this is the oocyte. Those ones go after ovulation, and these ones remain. Now, which cells constitute the endocrine ovary? We have the granulosa cells, these ones. These are the granulosa cells. And you have the thicker internal cells, these ones. Those are the cells that we have before ovulation. After ovulation, which means this one has gone away, they're the same cells that remain, but they form part of the corpus luteum now. So we give them different names. The granulosa cells become granulosa lutein cells. Those are cells of the corpus luteum. Thicker internal cells become thicker lutein cells. These 4 cell types are the cell types of the endocrine ovary. They are responsible for production of estrogen and progesterone hormone. Right. Now let's look at hypothalamo-hypophyseal ovarian hormonal axis, the control of ovarian hormone secretion. From the hypothalamus, we do have gonadotropin releasing hormone acting on the adenohypophysis anterior pituitary. The physiological effect there is to promote the secretion of gonadotropic hormones, just like we saw for testicular axis. The gonadotropic hormones here are FSH and LH, as we know. So G and RH come from hypothalamus, but FSH and LH come from the anterior pituitary. They act on the ovary. FSH act on the ovary to cause follicular development or follicular maturation. You can call it folliculogenesis. As the follicle becomes bigger and bigger, the number of follicular cells increase or granulosa cells increase, and that means that increased production of estrogen. And so FSH can be described to be stimulating estrogen secretion. That is what usually happens largely in the first half of the female reproductive cycle. At the mid-cycle, we have a luteinizing hormone surge, which leads to the event that causes ovulation. That surge of luteinizing hormone causes luteinization of the follicle. And so the cells that were producing estrogen or rather, they were producing estrogen before ovulation, now predominantly produce progesterone and less of estrogen. And so we can say that luteinizing hormone promotes progesterone secretion. Right, so that is the hypothalamo-hypophyseal ovarian hormonal axis. You can, at your own time now, look at the physiological effects of the ovarian hormones, both estrogen and progesterone. And you can look at that before pregnancy and during pregnancy, and even after that. So remember, before pregnancy, they are largely controlling the female reproductive cycles. And in an earlier lecture, we must have talked about the female reproductive cycles. All right, we will stop there. This will be your assignment, so we'll not discuss it here. We'll stop there. Thank you very much. That summarizes the whole lecture on endocrinology. Thank you very much.